Good morning, ladies and gentlemen. I'm Hyun Sung from South Korea. This time my topic is the endoscopic cervical posterior approach. Why I'm doing the posterior cervical approach. This is my curriculum vitae and disclosure. Yes, we can see like this case is 29-year female patient with a huge rupture disc, and the patient have a shoulder, the complete shoulder drop. In that cases, what kind of surgery will you choose? Douglas? What kind? Yes, like this case is very confusing, but I choose the posterior approach. Why I choose the posterior approach of the endoscopic spine surgery? We know already well now that there have so many complications of the open surgery like this postoperative hematoma and recurrent laryngeal palsy and dysphagia, Horner syndrome, and so many complications, sometimes very serious mortality cases. In the endoscopic spine surgery, we can find two kinds of method. One kind is anterior approach, and one another is the posterior approach. But I choose the posterior approach. Why? Anterior approach also already interests, but they are also so complicated anatomical structures to here. But posterior approach is more safe, and also can decrease the kyphotic problem and can approach it to the target point directly. In the posterior approach has several advantages. Firstly, we can preserve the muscle near completely in spite postoperatively, and also this endoscopic posterior approach can preserve the facet joint sufficiently. We can already well know that less than 50% can save the segmental function sufficiently. You can see here the preoperative and postoperatively. You can see the facet joint saved near more than 50%, and also this cause why we can preserve the facet joint sufficiently, because it can act as like a mobility of the endoscopic procedures. Because if we use this technique, we can save the facet joint sufficiently in spite of the sufficient decompression and discectomy. And also it can apply the, like this cases, some ASD cases also can apply the posterior approach, and we try to minimize the option to the patient. Yeah. But this is some surgical steps of the endoscopic decompression from the firstly cranial part, after then caudal part exposure, and then there we see the double root here, and we should be checking the location of rupture disc, where location of the rupture disc, and also we should be checking the vertebral artery, where is the vertebral artery location, and then we should caution to not damage to here. First step of the decompression, endoscopic decompression, to finding the V point, and then you can see the sufficient decompression of the shoulder area and axilla area, and you can see here the double root of the. Actually, double root is made by the motor root and sensory portion of the nerve root. And finally, we can find the sufficient decompression without any damage of the muscle and another structures, and save the cervical kyphosis sufficiently. And I will show three cases. You can see here the huge rupture disc and severe radicular pain patient. And firstly, ducking the V point, and then drilling the cranial part and drilling the caudal part. Then you can expose the rupture disc point here. Then you can remove the rupture disc sufficiently without damage the another structure. You can see here the muscle preserved completely with the preservation of facet joint sufficiently, and the patient's pain gone completely. Firstly, we saw this case. This case firstly came to C45 shoulder drop state with a severe pain and some kyphotic posture. But yeah, firstly, we checking this viewpoint and then remove the ligament flabum. Then you can expose the exiting nerve root. But in some patients, they need some pediculectomy. I'm doing the pediculectomy using the endoscope drill, and then we can operate to the target point sufficiently without any severe retraction of the nerve root. Only we directly expose the huge rupture disc target point directly without damage, open another structures near completely. You can see the huge rupture disc. Then we can remove the rupture disc without any serious retraction. And remove the ore. And finally, we checking the free nerve root without retraction or seriously. And the post-operative, this MRI taken 1 days after operation, you can see the some pediculectomy, and the patient shoulder drop recovered completely 1 month later. And one another case is this like some ankylosing spondylosis with severe cervical cyst with a severe neck pain patient. In that cases also anterior approach or posterior approach is not easy. In that cases also we can remove only this pathology without damaging another structures, and we can decompress, sufficient decompression with the sufficient removal of pathology and with the not damage the another structure sufficiently. I think that maybe the endoscopic, especially posterior approach, has several advantages compared to the previous operation technique. Like we can directly operate to the target point, and muscle preservation near completely, and the facet joint also preserved near sufficiently. And if we using the mobility of the working channel, we can approach it to the target point more deeply without damage to the structural function. And because of that, I believe that this is a real minimized option of the spine surgery. Thank you for your kind attention.